All right, let's jump right in and tackle eating disorders. We're going to cover the core clinical knowledge you absolutely need to know, focusing on those high-yield concepts that are just crucial for exams like the PEBC MCQ. So here's our game plan. We'll kick things off with how these conditions are classified. Then we'll get into the goals of therapy and the patient workups. After that, we are going to do a deep dive into the specific management for both anorexia and bulimia, touch on some special considerations like pregnancy, and then wrap it all up with some high-yield tips you definitely will not want to forget. Okay, first up, classification. Getting the diagnosis right is the absolute bedrock of treatment. So our first job is to draw a really clear line between anorexia nervosa and bulimia nervosa. So what exactly are we talking about when we say eating disorder? Well, at its core, it's any kind of disturbed eating behavior that ends up seriously impairing a person's physical health or just their ability to function day to day. This goes way beyond just dieting or being a picky eater. And this slide really gets to the heart of the difference. On one hand, you have anorexia, where the primary driver is restriction, which leads to a significantly low body weight. On the other hand, with bulimia, the defining feature is that destructive cycle of binging and then compensating or purging, all while the person often stays at a normal or even a higher body weight. Now, when we dig into the diagnostic criteria for anorexia, I really want you to notice how we classify severity. It's not based on someone's feelings or thoughts, it's tied directly and objectively to their body mass index, or BMI. This is so critical for assessing medical risk and figuring out the right level of care. Now, for bulimia, the focus shifts completely. Notice that severity has nothing to do with BMI. Instead, it's all about the frequency of those binging and compensatory behaviors each week. That's a huge distinction from anorexia and a key point to remember. So we've got the diagnosis down. What's next? Well, we have to talk about the clinical workup. This is how we gather all the objective data we need to build a treatment plan that's not only effective, but safe. The goals of therapy are, well, huge. It's so much more than just telling someone to eat more or stop purging. Of course, we want to restore weight in anorexia, but we also have to treat all the downstream medical problems like osteoporosis, manage the severe psychiatric issues like depression and OCD that often come along for the ride, and ultimately prevent a relapse. And the way we do this is super systematic. It really boils down to these 3 key steps. We always start with a compassionate but very thorough history. Then we move on to the physical exam, or we're looking for clinical clues. And finally, we use lab tests to see what's really going on under the hood. Okay, so when we're doing the physical exam, we're basically detectives looking for clues. Some signs are really specific to purging, things like swollen parotid glands, dental erosion, and of course the classic Russell's sign, those calluses on the knuckles from inducing vomiting. Others, like lanugo hair, that fine, soft, downy hair, are telltale signs of the severe malnutrition you see in anorexia. Now, looking at the lab work, there are 2 things that absolutely have to stick in your mind. First, for both conditions, checking electrolytes is non-negotiable. Malnutrition and purging can cause life-threatening imbalances. Second, look at the bottom row. An ECG is mandatory for anorexia. This is because the risk of serious cardiac complications, including fatal arrhythmias, is incredibly high. Okay, let's dive into managing anorexia nervosa. And this isn't guesswork. It's a very specific, stepwise approach that focuses first and foremost on medical stabilization and nutritional rehabilitation. This algorithm is basically our roadmap. So let's trace the path here. You'll notice the very first question right at the top is, are there any urgent medical or psychiatric red flags? We're talking about things like an abnormal ECG, severe electrolyte disturbances, or suicidality. If the answer is yes, that patient needs immediate medical assessment. If it's no, we move on to initial counseling. From there, we see if they're improving. If not, and they become medically unstable, they get escalated. If they're stable but still not getting better, that's our cue to start considering the medication options we're about to discuss. Now, a huge part of the non-drug approach is setting weight gain targets that are both safe and realistic. And as you can see, those targets are different depending on whether the patient is in the hospital or an outpatient program. The key here is that this has to be done slowly and steadily, because refeeding someone too quickly can be incredibly dangerous and trigger serious complications like refeeding syndrome. But it's not just about the food. We've got a whole toolbox of other vital strategies. Everything starts with building a strong therapeutic alliance. For younger patients, family therapy is absolutely essential. But check out some of the other things, like carefully managing excessive exercise and even using simple warming techniques, which can actually help reduce anxiety and support recovery. Okay, let's talk about a really common and distressing problem during refeeding, gastroparesis, or that feeling of delayed stomach emptying. Now, we've got a couple of tools for this. Dompridone is usually our preferred agent because it has a much lower risk of causing those nasty extrapyramidal side effects, the movement disorders like dystonia, when you compare it to metoclopramide. And this leads us to a super important safety question, the kind of thing that loves to show up on exams. When you're using a prokinetic agent like domperidone, what is that primary cardiac risk that you have to be watching for? And there it is, QTc prolongation. This isn't just a minor side effect. It can be deadly, leading to an arrhythmia called torsades de pointes. That's why we absolutely must get a baseline ECG before starting and follow up ECGs after dose changes, especially in this vulnerable population who might already have electrolyte issues that put them at higher risk. Now, this is a really interesting and maybe surprising point about olanzapine. We all know it can cause significant weight gain in other patient populations, right? But what the studies in anorexia nervosa show is that it helps reduce that obsessive anorexic thinking and anxiety without causing that same rapid weight gain. And that is key, because the fear of gaining weight quickly would make patients refuse it. So, this table is a great summary of how we use meds in anorexia, and the key thing to notice is that each one has a very specific job. We use low-dose antipsychotics like olanzapine and quetiapine to manage psychological symptoms, not to cause weight gain. We use prucalopride for constipation, zinc to help with weight restoration, and at the bottom, the most critical one of all, thiamine. This is absolutely essential right at the start of refeeding to prevent the catastrophic brain damage of Wernicke-Korsakoff syndrome. All right, let's switch gears and talk about bulimia nervosa. And you'll see right away that our whole management strategy pivots. We're moving away from a focus on weight restoration, and we're zoning in on breaking that destructive binge-purge cycle. Okay, here's the roadmap for bulimia. And right off the bat, notice the big difference. After we rule out any urgent issues, the very first line of treatment is counseling. Psychotherapy is the absolute priority. It's only if the patient isn't improving after a few months of good therapy that we then move down the algorithm and start to consider pharmacotherapy, like an SSRI. This therapy-first approach is a fundamental principle in managing bulimia. And the absolute cornerstone of that therapy is cognitive behavioral therapy, or CBT. The reason it's so effective is that it gets right to the root of the problem. It directly challenges and helps patients restructure those distorted thoughts and beliefs they have about food and body image that are fueling the whole cycle. It's our first line for a reason. So, when therapy alone isn't enough, and we do bring in medication, antidepressants are where we turn. And what's interesting is they seem to have a direct anti-bulimic effect, even if the person isn't depressed. They can be really effective, often cutting binge frequency in half for the majority of patients. Fluoxetine is the go-to with the most data, so it's a common first choice. Other serotonergic meds are good options too. But here is the absolute must-know red flag point. Bupropion is contraindicated. Let me say that again. Bupropion lowers the seizure threshold. Patients who purge often have electrolyte shifts that also make them more prone to seizures. You put the two together, and you have an unacceptably high risk. Okay, now for a really special population that requires some careful thinking. Managing a patient with an eating disorder during pregnancy and breastfeeding. This is all about carefully balancing risks and benefits. Now, this is pretty interesting. You might think pregnancy would always make things worse, but for about 2/3 of women, the symptoms of their eating disorder actually improve. That said, for that other 1/3, things can get worse, which is exactly why we have to monitor them so closely. So, what's the bottom line here? Any pregnancy in a patient with an eating disorder is automatically considered high risk. That's rule number 1, and it means a multidisciplinary team approach is a must. We always prioritize non-drug approaches, and for medications, every single one gets reassessed. For example, even though fluoxetine is first line for bulimia, we might consider switching to an SSRI with more robust safety data in pregnancy, like sertraline, after a careful discussion with the patient and their specialist. All right, let's wrap this up with some rapid-fire, high-yield therapeutic tips. These are the absolute key concepts you need to nail for your exams and for safe practice. First up, refeeding syndrome. This is a big one. This condition can be a killer, and the one word you have to burn into your memory for this is hypophosphatemia. That massive drop in phosphate can cause cardiac failure, respiratory failure, and death. Next, chronic laxative abuse. You cannot just stop these cold turkey. The key here is a slow taper. And I mean slow, like over months or even years, to allow the colon to wake up and regain its function. The selective 5-HT4 agonist prucalopride can be a really helpful tool to normalize bowel movements during that long process. Okay, here's a huge pharmacokinetic pearl for us as pharmacists. If you have a patient with bulimia and an oral drug just isn't working the way you'd expect, you have to ask yourself, is the drug even getting absorbed? You have to ask about the timing of their dose relative to any purging episodes. And that brings us to our final and maybe most critical question. This one ties everything together: nutrition, neurology, and patient safety. It's one of the most important things you'll do on the very first day of treatment. The answer, of course, is thiamine. Vitamin B1, this is non-negotiable. Giving it either before or with the very first meal is the absolute standard of care. Why? To prevent Wernicke-Korsakoff syndrome, which is a severe, irreversible form of brain damage. It's a simple intervention that saves brains.